Hello, everybody, and welcome to Geriatrics Part 1. Starting off, Gero usually means old. So, geriatrics is pertaining to older people. Gerontology would be like the study of old age. Chronological age. What I mean by this is aging is a complex process. It can be described chronologically, physiologically, and functionally. So it's kind of hard to describe how old someone is just by their age because everyone is different. So, chronologic age is not the most meaningful measurement of aging. You could have a 65-year-old that is pretty young and still functioning and is very active. Or you could have a 65-year-old that is living in long-term care and is pretty debilitated. So that's what I mean by chronologic age. Is not the greatest definition of if a person is old or not. Okay, then demographics. They talk about demographics on page 6 in your book. So that's the statistical study of populations. Like, if we want to know the demographics of our older generation in the United States, we would look at that. So, your book talks about how over the years, persons have been living longer. Like in biblical times, somebody probably only lived to the age of 20. But now, in today's time, predictions indicate if a child was born in 2010, they will probably have a life expectancy of 78 years or older. So the more technologically advanced we become, the longer people are living. Although the United States is not at the top of the list of living longer. Actually, your book says that the United States has steadily declined and now only ranks 42nd out of 223 countries. Some of these explanations for this is because of accidental and violent deaths, obesity, relatively high infant mortality, and the high cost of health care. So I would lean more, this is just my opinion, but our current healthcare situation in America is not equal and is difficult to obtain. Okay, our baby boomers are people that were born between 1946 and 1964. They talk about baby boomers on page 8. So there were a lot of people born during this time after World War II. So the baby boomers account for approximately 26% of all Americans today. So what does that mean? That means that we're going to have a lot of older adults by the year, they're already, these baby boomers have already reached the age of 65, and the oldest baby boomers reached age 65 in 2011, and by 2029, all baby boomers will be 65 or older. So because of that large group of population, in the year 2030, the older population will be twice the number that it was in 2000. So these baby boomers are going to put a large demand on geriatric health care. Personal and social attitudes regarding older adults and aging. So think about what is your own attitude towards aging. Is this something that you do not look forward to? Is it a negative view, or is it a positive? A time that you can retire, spend time with family. Also, think about the subjective and objective ways that aging is defined. Objective would be describing it. Somebody has impaired mobility, instead of it being subjective, saying they are frail. Objective ways would be measurable. And then also note the definition of self-identity, and that's the combination of attitudes and perceptions that people have about themselves. Do they identify as being old or elderly, or are they identifying as just further along in life, like middle age? Do they think 65 is old, or do they think 85 is old? Also, culture affects different attitudes towards aging. Some cultures value the aged person and lean more towards the older you are, the more wisdom you have, compared to other cultures that believe as you get older, the less useful you are. Gerontophobia is the fear of aging and the refusal to accept older adults into the mainstream of society. Two forms of gerontophobia is ageism and age discrimination. Ageism is the disliking of aging in older adults based on the belief that aging makes people unattractive or unintelligent or unproductive. Age discrimination would be like being biased towards a person because they're older. Maybe not hiring somebody because they're over the age of 60 in fear that they're going to retire soon. Or, as you see in Hollywood a lot, a person is in their peak from 20 to 30 years old, and then they're not hireable after that. Those would be some different types. Myths basically means things that aren't true or stereotypes of aging. On page 5 in your book, there is some myths listed, myths versus facts of older adults. So some myths or stereotypes would be like all older adults are pretty much all alike. Generally, they're alone and lonely. They tend to be sick, frail, etc. They suffer from depression, or maybe all, and you can just read up on that box there. Maybe all older adults are senile. Versus what is true. Older adults are a very diverse age group. They usually maintain contact with family. They usually live independently. Things like that. So know that we also have to look at our own myths that we start to believe about aging and try to determine what is wrong with our own thinking. Are we believing myths about older people? Some concerns we might think about with the aging adult would be economic concerns, social, and medical coverage. So really economically, a stereotype would be to say that older persons are poor, and that is not true. Just like with any age group, some are poor, some are actually wealthy. So yes, some of the poorest people are older adults, but some of the richest ones are too. In 2011, approximately 9% of the elderly population was determined to be at or below the poverty level. So when we think about economics, we think about our monthly income. And older adults usually have less of a monthly income. But if we're thinking about economics in that way, then yes, they probably are bringing in less money. But we need to look at assets also. Most older people, 85 or older, own their own home, or maybe don't receive as much monthly income, but have pensions or other earnings that they get their money from. They may have less required to live on if they're not paying for their home still, if they're not paying for other things that us younger people typically pay for. Okay, and then social, I'm not finding a lot about that in chapter 1, but I would say that has to do with getting older when their friends, some of their friends may be deceased. Some older people may be widowed. So this can affect their social life. And then medical coverage. Medicare is the government program that provides health care funding for older adults and those with disabilities. So most Americans older than 65 years do qualify for Medicare. There are different parts to Medicare. Part A covers inpatient hospital care, extended care in a skilled nursing facility, and sometimes some home health services and hospice can be paid for, but only after the patient pays an initial deductible and any copay expenses. Part B covers 80% of the customary and usual rates charged by doctors after deductibles are met. So not all people have Medicare Part B. They do pay additional for that. Part C is an Advantage plan that allows beneficiaries to receive Medicare benefits through private insurance companies. And then Part D is a prescription drug supplement. And they also pay for these additional parts to Medicare. Some people are on supplemental Medicaid, so they'd be on Medicare and then also get Medicaid benefits. Medicaid is usually for lower income people. So this may be available to older adults who meet certain financial requirements. Many of those who have assets do not qualify, like if they own a large house that's worth a lot of money. So these people are left with a Medicare gap that they must pay themselves. And then many older people buy private medical insurance. Often these are at unreasonable prices. And they get this private insurance to pay medical bills that are not covered by Medicare. So health care is a concern for the aging adult. Okay, the role of the nurse with an aging family. I couldn't really pinpoint this in chapter 1 either, but it's basically seeing the client as a person instead of just as their disease or condition that they're in. As nurses, we always want to be everybody's advocate, and that includes the older person too. Some people don't have family, and we must be their voice. So here's a quick question for you. The most significant issue that aging parents and their children must face is probably what? Lack of housing, behavioral issues, loss of independence, or lack of support groups. So the answer to that is loss of independence. So we may think that many older people are living in institutions, long-term care facilities, and that, but that is not true. Let's see, I don't remember how many your book said. I think that would be on page, it's on page 12. Only 3.6% of all older adults are institutionalized. As they get older, it does increase in percentage, but most of these people are being taken care of by their family. So that does put added stress on the family. So when we do take care of older persons, there's going to be some varied family dynamics. If there has always been an estranged relationship, that probably will continue as the person gets older. And many times when we're caring for older persons, us nurses like to say that we're taking care of their families also. As a nurse, you need to learn to be professional, and actually you are caring for the family just as much as you are for the person, especially in situations like end-of-life care. So you'll see some people that do live in long-term care. Maybe they have family visiting a lot. Some people may not have any family ever visiting. Maybe they don't have family, or maybe the family just is not close. So you'll see many types of coping differences among families and the aged person. Maybe that family's particular way of coping is to out of sight, out of mind. If it's difficult for them to see their older parent or family member with dementia, maybe their way of dealing with it is to not come visit. So I just want to read this little tidbit here to you. The older adults we care for are often very ill, and as nurses, we tend to focus on their physical needs, cares, and treatments. In our preoccupation with our duties, we can easily lose our perspective of the older patient as both a person and a member of a family. Some families show a great deal of interest or concern for their aging members. They visit regularly and interact with the patient and the staff. Other older individuals may never have family members visit them. Elder abuse, common signs, and prevention. So abuse starts on page 21. Starts with self-neglect, which is defined as the failure to provide the self for the self because of a lack of ability or lack of awareness. So your book lists some indicators of self-neglect that you can read. There's 7 of them there. Some things that you can notice in people is like a reduction in weight, poor hygiene, sores, rashes, body odor, anything that would indicate they're not taking care of themselves would be a type of self-neglect. Then it talks about abuse or neglect by the family. So taking care of an older person or anybody in long-term care, it's very stressful. So it may be accompanied by high levels of stress for the caregivers. Abuse and neglect happen every year at home and in facilities. So as caregivers, we need to be aware of this and be on the lookout for it. So you need to read in your book probably all of this, page 21 to the end of the chapter. on abuse. There's intentional abuse. So abuse can be physical, financial, psychological, or emotional. Neglect and abandonment are also are also considered abuse. Unintentional abuse would be like neglecting their care. It's a passive form of abuse where caregivers fail to provide the needs for the older person in their care, or maybe the spouse doesn't have the resources or the know-how to take care of a person in the home, and there is unintentional abuse going on. So go ahead and read about physical abuse, neglect, emotional abuse, financial abuse can occur among families and in institutions also. Abandonment, the responses to abuse. What we need to do, of course, we're their advocate, so we need to report any signs and symptoms of abuse. Under that, it also tells you how you should address any issues where you suspect abuse. So box 1-6 talks about any signs that the older person may be experiencing. So if they're excessively agreeing with you or compliant or excessively saying, "I'm sorry," that would be a sign. Poor hygiene is another sign. Burns, pressure sores, bruises. As nurses, anything like this, we need to be documenting very well and also assessing how this could have possibly happened. If you look on page 24 in your book, under this coordinating care, if I asked you the question, when is the likelihood of abuse in a facility the highest, what would be your answer to that? Under this coordinated care, it talks about it. And how some prevention signs also, how to increase or how to decrease staff stress so that abuse is less likely to occur. Also pay attention to box 1-7 on page 25. Some other forms of abuse are listed there. As nurses, we are mandated reporters, which means it is against the law if you suspect abuse and do not report it. So you would need to report it to your supervisor or call it into the state or report it to the local police. Now we look at theory versus fact of aging. Theories are just ideas of what could be occurring to cause age. So there are many theories that we'll look at, some different biologic theories and some psychosocial theories on aging. So theories have been looked at throughout history as people try to find ways to avoid getting older. My question to you is, why are theories important? So if you look on page 29, it tells you implications for nursing. Understanding all of the theories can help nurses recognize problems and provide nursing interventions that will help aging individuals successfully meet the developmental tasks of aging. That is why theories are important. Okay, so the different types of theories, biologic and psychosocial theories of aging and its impact on nursing. So, biological theories are trying to explain why the physiological changes of aging are taking place. So, why our body is changing. So, some of the a couple of the theories that I'll list here. Free radical theory is basically a theory that says that aging occurs because of cell damage that occurs in the body. Another theory, a biological theory that you can look at, page 29, the immunologic theory, proposes that aging is a function of changes in the immune system. According to this theory, the immune system, an important defense mechanism of the body, weakens over time, making the aging person more susceptible to disease. So it also proposes that the increase in autoimmune diseases and allergies seen with aging is caused by changes in the immune system. Then if we look at the psychosocial theories, these theories try to explain why older people have different responses to the process of getting older, so how we deal with it emotionally. So some of those well-known theories would be disengagement, the activity theory, life course or developmental theory, and other personality theories. So I would give you a hint for your test. Theories are so much fun and just not. They're really dry to learn. So I'll give you a hint. You need to know free radical theory, immunologic theory, and let's look at Erickson's theory, because we will cover that again in mental health, and Jung's theory. So that'll narrow it down a little bit for you. These next few slides all go with chapter 3 in your book. So normal aging process in body structure and function. You really need to read this entire chapter and especially pay attention to what's normal of aging. So in your book, it does have sections for each body structure, expected age-related changes, and pay attention to each one of those. I'm not going to be able to go through each one of these and list all of them, but you should know, like the integumentary system, the epidermis becomes more fragile. Senile lentigo or age spots may be normal as we get older. Also, the skin becomes more dry as we get older. Elastin fibers decrease, and then there's a thinner dermal layer. Wrinkles start to develop as we get older. There may be facial hair in women. Fingernails and toenails start to become more thick and more brittle. Sweat glands, we tend to sweat less as we get older. So I would encourage you to go through each body system and define what is normal of each system. So musculoskeletal, I'll point out the biggies here. Expected age-related changes on page 37. We do lose calcium as we get older. Actually, the change even begins between the age 30 and 40. So our skeletal bones do become thinner and relatively weaker. The intervertebral discs shrink, and the thoracic vertebrae slowly change with age. Your book does talk about kyphosis, but that is not a normal occurrence in aging. So I don't know why it's under that section. Connective tissue tends to lose elasticity. Muscle tone and mass typically decrease with aging. Muscle mass decreases. And you know that muscle weighs more than fat. So maybe the person is the same size they've always been, but may weigh less because they have a decrease in muscle mass. And then you can look over the common disorders in each body function. Okay, let's look a little bit with the respiratory system. Decrease in elastic recoil of the lungs, so we have a diminished air exchange. Mucous membranes in the nose are drier. The number of cilia decreases. Decreased vocal cord elasticity leads to changes in voice pitch and quality. So we do have a decrease in lung capacity, although it should not lead to debilitating conditions like lower oxygen concentrations or COPD or bronchitis, things like that. Although those are typically seen in aging, those would not be normal of aging. Okay, the cardiovascular system. Okay, your book says the heart does not atrophy or waste away with aging as other muscles do. In fact, the heart muscle mass increases slightly with age, and the thickness of the left ventricular wall also increases slightly. The heart valves do show some degree of thickening and calcification with aging, resulting in mild degrees of mitral valve regurgitation. The endocardium and the endothelium do lose some elasticity with aging. Orthostatic hypotension. We don't respond as quickly to postural changes as when we were younger. Okay, the gastrointestinal system starts on page 49. So expected changes, we do have the oral cavity. Some of the gingival tissue may recede, and the bonds holding the teeth in place may loosen some. The ability to bite and chew can be impaired, but it should not be significant. And it's not normal for older adults to lose their teeth. Really, if we take good care of our teeth, they should last. In the stomach, we do have a decreased production of intrinsic factor, and you know that affects our vitamin B12 absorption. As we age, we do have a decrease in gastric mucus production. So our and peristalsis does slow down with aging also, which can lead to constipation. But also our gastric mucus production leads our gastrointestinal system to not be digesting and absorbing nutrients as well as when we were younger. Urinary system starts on page 53. Expected age-related changes. The kidneys do decrease in size. But they're still able to remove waste adequately and maintain normal blood levels. The nephrons and collecting systems of the aging body are less sensitive to the effects of antidiuretic hormone. Less sodium and water are reabsorbed, and more potassium is lost. As we get older, we do have a reduction in the size of our urinary bladder, which leads to decreased bladder capacity. But that does not mean that incontinence is a normal part of aging. It is not. I'm just briefly going over these. You guys will need to be reading it in detail. Our nervous system starts on page 55. So some expected age-related changes. So cellular changes do occur in the brain, leading to a reduction in its size and weight. There's a 3% reduction in brain tissue. Mental function is often changed as we lose cells in our brain. Cerebral blood flow does decrease. So because of this, our motor responses do take longer when we get older. And as we get older, we slow down in walking and talking. They become, and our reflexes are more sluggish than when we were younger. Some loss of coordination is common, but not enough to be causing falls. Okay, next would be your special senses. So those start on page 60. That would be with the eyes, ears, nose. So look for the normal or expected age-related changes that go along with the special senses. So we do have some loss of hearing, but it shouldn't be enough to have a hearing aid or have any marked depression in our hearing. Next would be the endocrine system. And let's see, that starts on page 66. But the expected age-related changes are on 67. We do have a decrease in the production of thyroid-stimulating hormone. Our metabolic rate does start to decrease as we get older. And many different endocrine functions do decrease with age. You'll have to read up on all those. And then reproductive system starts on page 69. So on page 70, it talks about the expected age-related changes in women, and then on page 71, the changes found in men. This is probably going to be a biggie on your test, so I would say read this entire chapter. What's normal, and then what are some common disorders seen with aging. That doesn't mean it's normal with aging, but some of the problems people do have as they get older. I've left this slide blank so you can fill in. I would go with each system and just look over what are some common diseases in aging. And here again, you'll need to know what is the normal aging process versus a disease process. Perception and cognition with nursing interventions. Normal cognitive perceptual functioning, and we need to look at cognition and intelligence, cognition and language. So feedback from others affects our perception of ourselves. People who feel capable of controlling what happens perceive things differently from those who perceive no control over their lives. Choices regarding activities of daily living are determined by and are reflections of an adult's self-perception and level of self-esteem. So if they're isolating, if they're not getting out and doing the things they enjoy, this could be a reflection of poor self-esteem. Aging individuals develop their own perceptions of aging. Many older adults do express some dismay with the realization and can even identify a particular moment when they perceive themselves as old. Successful aging is not so much a matter of years lived or health status, but rather a matter of attitude. Older adults who have a poor self-concept throughout the years are not likely to gain self-esteem when they get older. Older adults who have a healthy level of self-esteem during their younger days may experience some problems when they get older, but these are often a result of societal attitudes. Although older people do have loss of physical and functional abilities, and those can be damaging to self-worth, loss of the emotional support of loved ones is even more devastating. The friends and loved ones who made life worthwhile slip away one by one. The positive messages that a person is worthwhile, lovable, and loved becomes less frequent, and the reasons for living disappear. So we need to always encourage self-esteem and be monitoring their self-perception. Some things we need to be looking for that could indicate self-perception or self-concept problems would be if they stop their normal routines, if they're neglecting their self-care, if they're unwilling to talk, if they're agitated or irritable, suspiciousness or unjustified fears, mood swings. So we need to assess the older individual's perception of self, including their strengths and support systems. So other interventions to help the older adult with self-concept would be establishing a trusting relationship, providing care in a non-judgmental manner, Encourage the person to look at and touch any affected body areas. This will help with their, if they have impaired body image. We need to focus on their abilities, not their disabilities. Explore their feelings and concerns. Demonstrate acceptance of older adults as people with value and self-worth. Encourage them to participate in self-care activities. So we always want to encourage independence. Whatever they can do, we need to be taking the time to let them do that. That's a big thing with self-esteem and self-worth. We need to provide opportunities for reminiscence. Let them talk about their past, their happy memories of when they were younger. And also encourage the family to participate in reminiscence by providing pictures or items that bring back memories of happy times. And we need to encourage families to communicate positive feelings to the older adult. And now, this all comes from chapter 11, by the way. And then let's touch on fear a little bit. Fear is a feeling of dread or apprehension regarding an identified source. So the most common fears identified in older adults are a fear in disruption of their lives or routines, like if they had to move to a long-term care facility, or if they encounter a disability like they've fallen or broken a hip. Crime and victimization is also a fear. They have a fear of loss of loved ones, fear of disease, injury, pain, and suffering, a fear of loss of independence, a fear of financial problems, and a fear of loneliness. So often older adults, their number one fear is not death necessarily. It's a combination of these other things. Roles and relationships in the aging population. So a role is a socially accepted behavior pattern. People tend to establish their identities and describe themselves based on the roles they play in life. So roles are like man, woman, husband, wife, adult, senior citizen, parent, child, son, daughter, teacher. What roles do you have? You're a student, a mother or a father, a wife or a husband, a girlfriend or a boyfriend. So these roles define who we are, and our relationships are based on our roles. So the older adult must adjust to many predictable role and relationship changes that are associated with aging. So some of these changes would be like retirement, an altered relationship with their adult children. They're no longer children and they're now adults. So that's a change in role. Changes in housing will affect their roles and relationships. Loss of valued possessions and friends because of relocation or death. A loss of a spouse to death, loss of health or their independence can change their role in relationships. Older persons who outlive their families and friends often feel that their lives are without purpose. So we need to reassure and encourage reminiscing. Many older adults change housing arrangements out of choice or necessity. So they have, there's another loss of their home. Moving to smaller places commonly results in the sale or distribution of their personal possessions that they've accumulated over a lifetime, so they can feel a loss over that. When older adults lose health and independence, they lose control over their own destiny. and they're often at the mercy of others, either family or strangers, for their care. Some nursing processes that we associate with role in relationships would be dysfunctional grieving. They could be having a problem adjusting to losing spouses or their home or retirement. Social isolation can be another one, or impaired social interaction. And interrupted family processes could be another nursing diagnosis that could be affecting them. So we need to think about the interventions that we would use for these type of problems. Most social isolation is it A, intentional, B, unintentional, C, unavoidable, or D, perceptual? And the answer is B, unintentional. All of this comes from chapter 12 in your book. If you want to glance over that, glance over the interventions especially. So here we look at physical, emotional, and behavioral signs of stress and aging. So those can all appear as physical signs, which include cardiovascular, respiratory, musculoskeletal, GI, urinary signs, cognitive signs, emotional, and behavioral. So stress is a fact of life. The stressors may change throughout life, and stress affects people of all ages. The major stressors of aging relate to losses, loss of ability, loss of loved ones, their home, are all stressful to older adults, and this affects their physical and emotional status. Stress can result in behavioral changes, and excessive stress levels are harmful. Coping mechanisms need to be used and encouraged to deal with stress. The effectiveness or ineffectiveness of these coping strategies is a concern to nurses. So we need to look at the interventions that reduce stress and support positive coping mechanisms that can be beneficial to the older adult. These are all in Chapter 13. Nursing interventions are talked about on page 232. I would just read over those, like encouraging verbalization of feelings, discuss the reasons for the move or change, include the older adult in care planning, encourage positive attitude, maintain continuity of care, encourage the use of familiar objects and belongings. If they do have to move into a long-term care facility, we need to bring some items from their home that makes it feel homey and looks familiar to them. Sexuality changes in the older adult. Sexuality is a normal physical need throughout life, even as we age. Some factors that affect sexuality in older adults. In women, they may experience changes in their reproductive system related to decreased levels of progesterone and estrogen. In the past, hormone replacement therapy was standard treatment. But these days, this is not typical because there are concerns about the safety of hormone replacement therapy, especially for women who have pre-existing cardiovascular or liver disease, and those that are at risk for breast cancer or endometrial cancer. This hormone replacement does put them at increased risk for these problems. Some common changes that may result in discomfort or pain during intercourse would be, like in women, would be irritation of the external genitals, thinning and dryness of the vaginal walls, and alteration in the levels of normal microorganisms in the vagina that results in an increased risk for vaginal yeast infections. These are all results of normal hormonal changes that occurs in women during the menopausal years. In men, orgasms may take longer to achieve and a shorter duration than when they were younger. Ejaculation is less forceful and a smaller volume of seminal fluid is released. Some men can have a loss of erection that occurs quickly after orgasm. The time between orgasm increases, and orgasm may not occur with every episode of sexual intercourse. Many disease processes can interfere with normal sexual function in men, as do a lot of medications that men and women both may be on. Incontinence is not a normal thing with aging. It should not interfere with sexual relations, but it can because it may cause people to avoid sex because of embarrassment. Joint pain, cardiac problems, hysterectomies, mastectomies, depression, excessive alcohol, and certain medications, especially antidepressants, can all affect sexuality. Also, in the aging, if the person has lost their sexual partner, if they have become a widow or something, this also affects their sexuality. Young people may not be comfortable with the thought of sexual activity among older people, thinking that it's offensive or abnormal, but sexuality is a normal physical process of life throughout all age groups. Even healthcare professionals can be unaware or uncomfortable about addressing the sexual needs of older adults. Fear, shame, or embarrassment causes many older adults to hide their sexual interests and activity. We need to be aware of STDs in the older population. This can be a possibility, especially if they're practicing unsafe sex or have multiple sex partners. We need to be assessing and providing education on this. Some older people who have concealed their sexual orientation in their younger years may be more comfortable expressing it as they get older. So we must be careful to recognize the sexual needs and concerns of lesbians, gays, or transgendered people and respect their choice of sexual orientation. We need to give them adequate privacy. This may be difficult, even for married couples who reside in the same institution, especially if they are needing regular medical or nursing care. But we need to remember privacy is a high priority. Touching, hand-holding, and cuddling are encouraged. It should never be discouraged as long as it's two consenting adults. A closed door must be respected when privacy for intimacy is desired. The nursing process, sexual dysfunction is a nursing diagnosis for issues with sexuality. Some of the interventions would be encourage verbalization of concerns. An example would be like talking about erectile dysfunction with a man and medications that may be used for this. Another intervention would be providing privacy and protecting the sexual dignity of confused older adults Sometimes confused patients are acting out sexually and they may not know what they're doing. We should never make fun of or belittle these patients. If they're in a public area, we need to remove them from that area and provide privacy for them. This is all in chapter 16, if you would like to review that. End-of-life care and end-of-life decisions. I would encourage you to look over your ethical definitions like justice, autonomy, non-maleficence, and beneficence. There is probably going to be a question on those. So advanced directives are basically advanced decisions that we make for the care that we will receive when we can no longer make those decisions. So some of the examples of advanced directives would be like your living will or assigning a durable power of attorney. Anyone 18 years or older can legally complete an advanced directive. So a durable power of attorney for healthcare is a legal document that's drawn up that transfers the authority to make healthcare decisions to another person, probably a family member or someone that person trusts to make decisions for them. A living will informs the physician that the individual wishes to die naturally, or if he or she develops an illness or receives an injury that cannot be cured, they guide the family and medical professionals in planning care. So the living will would include if they want to be on mechanical breathing measures, or if they would like nutritional supplements per feeding tube, or those kind of instructions on what they do and do not want to prolong their life. Stages of death and dying are also in chapter 15, End of Life Care. So our Elizabeth Kubler-Ross developed the stages of grief. So this can be stages, the person that is actually dying can go through these stages, or family members experience these stages when they're dealing with the death of a loved one. And these stages go along with any loss, not just death. Could be the loss of a job, a divorce, anything. Usually people will go through these stages with any grieving. They don't have to go in any particular order. Sometimes they are never finished going through them and they start going through the stages again. So these are listed in sequence, but they can move in and out of the stages unpredictably and erratically. So denial is having a hard time accepting the truth. Numbness protects the survivor from the intensity of the loss. And it's just not, they're having a difficult time accepting the reality of the loss. Anger is a normal stage. Also, feelings of anger are often directed at the deceased or at God because the survivor feels abandoned. Anger is one method for dealing with the feelings of helplessness and powerlessness. And anger does tend to decrease over time. I'm looking at the box 15-3 on page 259. Bargaining is another stage of the grief process, and survivors try to identify whether something else can be done. Maybe they are making a deal with God saying, I promise if I never do this, if you'll just heal me from cancer, I will this, and this. They're trying to make deals to avoid their grief. Or, God, if you will just take me instead of my spouse, or things like that. Depression is feelings of emptiness, loneliness, and isolation. And then acceptance. There's no set time for grief. Acceptance and healing occur slowly as the person works through his or her feelings. Okay, and then imminent signs of death. On page 258, it talks about the 9 indicators of imminent death. That means death is near. So some of these may include increased sleepiness, decreased responsiveness, confusion in a person who has been orientated, hallucinations about people, sometimes deceased family members. This is kind of an unusual phenomena that's really kind of creepy, but they will see dead loved ones in the room with them, be talking with them. Increased withdrawal from visitors or other social interaction. They tend to start having a loss of interest in food and fluids. And actually, as death is becoming near, we should not be forcing food and fluids on that person. And sometimes that's difficult to have the family members understand that food and fluids at this point is, if they want it for comfort measures, that's fine. Usually somebody is not going to die of a lack of food or fluid. Yes, we need to be offering them fluids, but having them eat right before death is not a usual thing. Of course, we need to offer it, but mainly keeping their mucous membranes moist, their lips moist, is of more importance. A loss of control of bowel and bladder in a person who's been continent before. They usually have altered breathing patterns, such as shallow breathing, Cheyne-Stokes breathing, rattling or gurgling respirations. This can be quite alarming to family members especially, or healthcare providers that have not experienced death before. Sometimes we call this rattling a death rattle, but that's not a very nice term to say. You wouldn't want to say that to a family member or the person who is dying. Sometimes this thick mucus can be suctioned out, but usually it is unable to be suctioned out, and some medications can decrease this rattling also. Involuntary muscle movements and diminished reflexes are also signs of imminent death. It's important to know that the last, they say, the last sense to go is hearing. So when you are taking care of somebody who is dying, always be aware that what you say and what's going on in the room, hearing is the last sense to go. So you should be speaking to the person and in a way that is acceptable. I have included this picture for geriatrics. This pretty much highlights the biggies in geriatrics. special considerations for older adults. Some of it will be covered in the next lecture that Shelley will provide. But basically, older adults have a decreased tolerance to meds, so we need to be careful when administering sedatives or any type of narcotics or anything that's going to decrease levels of consciousness, even if they're antihistamines. Also, we need a decreased IV rate to avoid fluid overload. They have an increased risk of respiratory depression, pneumonia, disorientation, skin breakdown, and falls. So you'll need to look at the different systems to understand why they are at increased risk of these. Also, they have an increased risk of problems with circulation, increased risk of nutrition problems, constipation, fluid and electrolyte balance. They are more susceptible to sudden increase in confusion, and usually this is a cause from urinary tract infections, hypoxia, or electrolyte imbalances. We need to treat coexisting medical disorders, cardiac problems, peripheral vascular disease, and neuro disorders. This is all for my section of geriatrics. I wish you all good luck on your first exam.